Hi, my name's Jake. I'm going to be demonstrating a pediatric mask induction and intubation. The patient that I have today is a 5-year-old male. He weighs 20 kilograms and he is here for a tonsillectomy. The only significant medical history he has is some OSA, and that's related to enlarged tonsils. I am going to go, before I go into the OR, I'm going to go and meet the patient. I'm going to get to know him, and I'm just going to do a quick little assessment. I'm going to check his airway. I'm going to look. I'm going to actually see that he does indeed have large tonsils that could be causing the OSA. I'm going to make sure he doesn't have any loose teeth. I'm going to make sure his neck is good. He doesn't have any masses and that he has full range of motion. I'm going to listen to his heart and lungs, make sure there's no issues there that could put him at an increased risk for bronchospasm or laryngospasm. Once I'm done with my assessment, I'm going to now interview the patient's parents and review any past medical history. They just say that he's snoring. He has no other known illnesses, but I am going to make sure that he hasn't had anything recent, that specifically any upper respiratory illnesses that could lead to an increased risk of laryngospasm. I'm going to review his current medications, make sure he's not taking anything, check for any allergies, and then most importantly, I'm going to check if he has had any previous surgeries with complications, or if there's any family history of complications with anesthesia, specifically looking for malignant hyperthermia risk factors, as that is an increased risk with pediatric patients. And then I'm going to confirm that he's been NPO, make sure he hasn't eaten or drank anything within the last 6 hours for food or 2 hours for liquid. Then I'm going to go over the anesthetic plan with the parents. I'm going to discuss that I'm going to bring him back. We're going to lay him onto the bed. We're going to make sure he's comfortable and warm, and then I'm going to put a mask on, give him some gas to make him fall asleep. Once he's asleep, we will insert an IV, give him some IV anesthetics to make him into a deeper state of anesthesia. At that point, I will insert a breathing tube, and we're going to secure that, make sure he's comfortable throughout the surgery, and then once the surgery is over, I will take the breathing tube out, make sure he's safe, take him to PACU, and then the parents can meet him in the recovery area. Once I obtain consent, I'm going to leave the patient, go into the OR, do my machine check and room setup. So I'm going to come into the OR, make sure I have a BVM, make sure my monitor is here and that the machine is plugged in to the wall for power, and also that all my gas supplies are connected. I'm going to check the tanks on the back, make sure I have appropriate pressures in the tanks. For oxygen, I should have 1,000 psi, and for my nitrous, 745 psi. And then my wall supply should have pressures of about 50 psi in all of those. I'm going to check and make sure that my sevoflurane, which will be my gas of choice today, is ready to go and filled. I'm going to check the interlock system really quick and perform a low leak test. Once that's done, I'll turn the machine on. While the machine's getting booted up, I'm going to make sure I have all the supplies I need. So first I'm going to start with the airway, since he does have OSA and large tonsils. I'm going to make sure I have multiple OPAs. One that is appropriately sized to him that I did in the room, which should go from the back of the jaw to the corner of the mouth. And then I'm going to just have a slight size up and down, just to make sure if his anatomy is different, I'm prepared. And then I'm going to have my ET tubes ready. We're going to be using oral rays. For this patient who's 5, he should have a 5.5 ET tube. So I'll have a 5.5, but I'll also have a 6.0 and a 5.0, just in case, once again, I need a different size for that. I'm going to have a MAC 2 blade ready, and with the MAC blade, it's going to go and be inserted into the vallecula. At that point, it will open up the epiglottis and allow me to visualize the cords through indirect lifting of the epiglottis. I will also have a MAC blade just in case. With the MAC blade, it is a straight blade. It's going to go and it's going to actually insert over the epiglottis. Oh, sorry, Miller blade. Miller blade is straight. That's what's in my hand. That's going to go inside the epiglottis and lift so that I can see the vocal cords. But I'm going to start off with the MAC 2 blade. I'm gonna get all my medications ready. So I'm gonna make sure that I have propofol and fentanyl for induction. Before I go through that, I'm just gonna have my Apple medications ready, which are atropine, propofol, phenylephrine, lidocaine, ephedrine, and succinylcholine. The most important of those that I'll actually use are propofol, fentanyl, succinylcholine, Decadron, and then I will also have Zofran. And for propofol, my dose is going to be 2 to 3 milligrams per kilogram. Fentanyl 1 to 2 micrograms per kilogram. And for this 20 kilogram patient, that's a dose of 40 milligrams of propofol and 20 mics of fent. My Decadron dose will be 150 mics per kg. Zofran will be 0.1 milligrams per kilogram, which equates to 3 milligrams of Decadron and 2 milligrams of Zofran. And then for my atropine, it's 0.02 micrograms per kilogram. It has to be more than 0.1 milligrams. In this case, I don't have to worry about that. And with Sux, it's 2 milligrams per kilogram IV or 4 milligrams per kilogram IM. So those doses would be 0.4 milligrams of atropine, which is good for IV or IM, and then 40 milligrams of Sux IV or 80 IM. Once I have my medications ready, I can go on, and now that my machine's on and ready to do the rest of the checks, I'll check my vaporizer, check my CO2 cartridge. I'm gonna make sure that the ventilator settings are, like the alarms and everything, are working and on. My equipment is patent. I'm gonna perform a high pressure leak test. So I'm just gonna include this, close my APL valve, and then I just need to get the pressure greater than 30. This will also check the high pressure alarm, make sure it's good for 10 seconds. And I'm gonna slowly open my APL valve back up, and the pressure should follow whatever I had the APL valve set to, so that works. Completed that, I have all my equipment ready. I have suction, I have my EKG, I have my blood pressure and SpO2. And I also, by doing the high pressure leak test, check the scavenging system. So the machine check is good and ready to go. I'm good to go get my patient. My ventilator is set to the appropriate settings for this patient. I have him in here. I'm gonna now place the mask over and make sure it fits good. It should go over the bridge of his nose, over his cheeks, and on his chin. I'm gonna use the CE method, which will be good also to open up the airway because I can perform a jaw thrust, but I still have my OPAs if I need them. I'm gonna put my oxygen to 3 liters, my nitrous up to 7 liters. If the patient's calm, I can put my SIVO to 2% to start and then slowly increase up to 8%. If at any point the patient becomes uncooperative before I hit that 8%, I'm just going to perform an SLB, increase my SIVO to 8%, and hold on until he goes to sleep. And then while I'm doing that, I'm going to be looking at my monitor. I should see an increased FA-FI ratio, so my FI should be much higher than my FA, but I should see the FA slowly climbing up. And that just means that my ventilator is working appropriately with the anesthetic gases. Once I reach stage 2 anesthesia, this is the excitatory phase. I will probably see agitation, I could see breath holding, tachycardia, dilated pupils. Any stimulation needs to be avoided because it does put the patient at a high risk of laryngospasm. Once we exit stage 2 and enter stage 3, which is the surgical anesthesia state, I'm going to turn off my nitrous, turn down my SIVO, and then make sure my oxygen is just whatever it needs to be. We're going to place an IV, get the patient more ready to go. I'm going to now put the patient into the sniffing position, make sure his airway is good and open for me, give him a couple breaths to make sure I can ventilate, and then we're going to turn off my gases. I'm going to leave this right here, and now I'm going to get my equipment ready to intubate. We're going to give the dose of propofol and fentanyl, and then I'll have my ET tube ready to go. Patient's now had his propofol, so we're going to go ahead and intubate the patient. Perfect. I'm going to secure the tube. Now with an oral ray, the appropriate size tube, We know it's deep enough once it reaches the elbow because it is appropriately sized. So we're good there. I'm gonna hook this up. I should see fogging of the tube. Make sure it's secured. Equal chest rise, no rising of the stomach. I will listen to the chest, make sure that's confirmed, and listen to the stomach. And then I should see an increase in end-tidal CO2, which means it's placed appropriately. Once he is intubated, I'll turn my gases back up to 2%, turn my oxygen up to whatever it needs to be. And then now I'm going to give some Decadron and Zofran since this is a short case to help with the post-op nausea and vomiting. I'll put some tape over his eyes, and then we're good to go on with the case. Once the case is over, we're now going to be looking for the emergence. I'm going to turn off my gases. For extubation, you can either do a awake extubation or deep. Awake would be when they're returned to stage 1 anesthesia. Deep is in stage 3. The key is to not do any of this during stage 2. So advantages of an awake extubation is there's a return of airway reflexes, which protects the airway. There's a decreased risk of aspiration. Disadvantages, especially with the tonsillectomy, there's an increased risk or increased instance of coughing and gagging and cardiovascular stimulation. So that would put an increased risk of bleeding for him. For deep extubation, advantages are a smoother emergence, little to no coughing. Disadvantages is there are obtunded airway reflexes, so I will want an OPA ready. Where he had OSA before, I want to make sure I have it ready just in case it wasn't the tonsils causing it. There's also hypoventilation. If they're a little too deep, there's an increased risk of aspiration. And there could be, if it's not deep enough, there is also a risk of laryngospasm. So we're going to go ahead, we're going to do a deep extubation. So I'll untape that, untape his eyes, uncuff the tube. And all our gases are off at this point as well. And then extubate the patient, hook him back up. At this point, I'll just continue mass ventilating and monitoring closely, make sure his airway's good. He should also be spontaneously breathing, so I'll just be helping him if I need more volumes. Now, risks that could happen during this time is bronchospasm. A risk is asthma or any type of pulmonary irritation, which this patient doesn't have, but signs of that would be wheezing and high airway pressures. Treatment's 100% oxygen, manual ventilation to assess how severe. I can then deepen the sedation with sevoflurane, administer beta-2 agonists such as epinephrine or albuterol, and kind of just treat it that way and wait it out. There is also a risk of laryngospasm, and this is severely high in pediatric patients. So this occurs especially during intubation or extubation in stage 2. The signs are a loss of air movement or high-pitched squeak that's dependent on a complete versus incomplete laryngospasm. And complications can result in hypoxia, which would lead to bradycardia. The number one treatment is positive pressure ventilation. So I'm going to turn my APL valve, or I'm going to close it, and then I'm going to squeeze my bag, not necessarily squeeze, but just hold on to maintain a pressure of 20 centimeters of water. And then if that doesn't work, I can deepen the IV anesthesia with more propofol. If that still doesn't work, I can give IV or IM atropine and succinylcholine. Now with bradycardia, that's the last complication we're going to talk about. The number one cause is hypoxia, so the number one treatment then would be appropriate oxygenation. Succinylcholine could also cause it, so atropine would be the treatment in that case. And we could also give glycopyrrolate. The dose of atropine has already been discussed, but for glycopyrrolate, it's 0.01 milligrams per kilogram, and that would be 0.2 milligrams IV for this patient. Thank you.